Good afternoon. I'm Julie Kenville, president of the MUHC Foundation. Welcome to Health Matters, a weekly conversation with experts about the medical issues that matter most to you and your family. During this unprecedented global crisis, we've been witnessing an overwhelming amount of misinformation about COVID-19. Our objective is to bring you behind the scenes with the experts on the front lines. They are caring for our community and leading the global battle to find a cure and a vaccine. They're joining me today to answer your questions, so please do submit your questions on the Q&A. Dr. Bruce Mazer is Interim Chief Scientific Officer of the Research Institute of the MUHC. Dr. Matthew Cheng is Associate Professor of McGill University. He is also a practicing physician in infectious diseases at the MUHC. Thank you so much to both of you for joining us today. Bruce, I'm going to start with you. We've been reading a lot about COVID-19 antibodies. Can you explain to us what exactly are antibodies and how does the immune system really work?
Hi, Julie. Thank you so much for inviting me. It's a pleasure to meet all of you virtually and to be able to talk to you a little bit about immune system and antibodies and COVID-19. So we are all born with antibodies. However, antibodies are proteins that circulate in our blood, and they do several things, mostly in helping to defend us. They trap and help other cells kill bacteria, viruses, even funguses, and even things like parasites. And we know that they also work on pollens, which is why we all have hay fever at this time of year. Antibodies, though, that we're born with are very immature. There's a very limited natural repertoire of these proteins that understand which things are foreign and which things aren't. So over time, with exposure to things, with exposure to infections or vaccines, our antibodies become more and more sophisticated. The more we recognize things, the better they are at catching the bad guys and improving your health.
And is there a way that we can boost our immune system? I've read recently that you could take vitamin D, for example, to reduce your risk of COVID.
So lots of things help our immune system function, but there's no magic bullet. There's no magic pill that will allow your immune system to just become more supercharged. Taking good care of yourself, having a normal diet, having normal vitamin levels, all help your immune system work normally. But the thing that helps our immune system get educated is either when we're exposed to infection or for severe diseases that we get vaccinated. And the vaccines certainly help our immune system learn what to fight against.
Well, we'll certainly speak a lot about vaccines today. Matthew, I'll turn it to you. Now, you've been seeing patients on the COVID units. You're involved in vaccine development at the MUHC. You're also involved in clinical trials for a variety of different medications. I understand that you've received great recognition from the federal government recently, and you've been asked to serve on the new federal government task force and secretariat. Can you tell us about those and what is your role?
Sure. First of all, thank you very, very much for the opportunity to come chat today. I greatly appreciate the invitation. So the COVID-19 Immunity Task Force is a nationwide initiative that was funded by the federal government to better understand the scope of the pandemic in our country. And the way that it plans on proceeding is to measure antibody levels, the same ones that Bruce was talking about, to the virus, in order to get a better sense as to the proportion of individuals that have been infected. And the reason that's so critical is because it allows us to understand the effectiveness of our current public health mitigation strategies, and also helps inform future policy. And it's part of a greater initiative to help Canadians go back to work safely and in a good environment.
Now, is McGill playing a particular role overall in the federal government strategy?
Right. So we're playing a really large role in collaboration with others across the country. But this initiative, which was spearheaded by Kate Hankins and Timothy Evans at McGill, has a really strong MI4 and MHC presence, with myself being asked to lead the diagnostic section of this COVID-19 Immunity Task Force along with some of my colleagues. And we hope to be able to determine which would be the best antibody test to implement for various patient populations. And we'll be testing novel diagnostic testing strategies to help being able to go after remote communities and understand how the virus has affected the most vulnerable.
Now, Bruce, many of our McGill MUHC physicians, like Matthew, are serving and playing key roles in the World Health Organization and in global healthcare associations. Now, why is this important to you as leader of the Research Institute?
So this is one of the most fun parts of my job, to be able to work with people like Matt and Don Shepard and Marcel Baer and Tim Evans, Vincent Muser, Don Vin. There's dozens of people who've been very active at the Quebec level, at the federal level, the city public health, David Buckridge, who's been on the government task force for predicting COVID-19 spread and making policy plans. When you are an organization like ours, you need two things to make sure that it's successful. The first is you need great people, because great people attract other great people. If you don't have the people who are motivated and high achieving, it's very hard to do recruitment. The other thing is that we as healthcare professionals and as clinician scientists and basic scientists in the healthcare world, we have a very strong ethic towards trying to make change. And whether it's change on the local level, provincial level, national, or global level, as is the case with many of our investigators, this is what we're here for. And if we're not here to be able to provide strong, novel, innovative technology and innovative diagnostics and innovative care, then we're not fulfilling our mission.
Now, both of you have mentioned MI4. I think it's important for us to describe what that is. The MUHC Foundation and McGill University made a unprecedented commitment 3 years ago to invest over the next decade $120 million to help build MI4. And our long-term objective is to build the first comprehensive institute in the world for infectious and immune diseases. What's wonderful is that the infrastructure that we've built, and it's 250 researchers right here in Montreal, and the research infrastructures and more than 5,000 employees, all of that is allowed us to really have a true impact on the COVID-19 battlefront from day one. And researchers here in Montreal and at the MUHC and MI4 were mobilizing back in January. Now, Matthew, I'm going to turn this to you. We have hundreds of patients, MUHC patients on the line today. Can you help us understand why that should be important to them to have an important academic hospital right here in Montreal?
So I have the privilege of participating in running clinical trials at the Royal Victoria Hospital and the Montreal General Hospital as part of the MUHC. And I use the word quite specifically that it is a privilege. Since the beginning of the pandemic, and even this morning, right before getting on this webinar, I was able to consent and recruit a patient to a clinical trial. And the story is often the same. When I first talk to the patient and their family, a lot of them are saddened, they feel depressed. A lot of the elder comorbid patients view this almost as a death sentence. And the opportunity to offer a clinical trial brings about a lot of hope. And a lot of the patients I've recruited have done really well. Now, I'm not saying it's because necessarily of the drugs that we administer, but certainly I do know that participating in a trial changes the outlook of things. And that is one of the beauties of being able to do clinical trials here, is that we're not only offering hope, but we're offering treatment possibilities that otherwise wouldn't be available to these patients.
Now, Bruce, one of those clinical trial that's about to launch under your leadership is the Living Lab. Can you tell us about that?
Absolutely. So Matthew was talking about the task force and how we have to be able to create safe work environments. One of the most puzzling things about our pandemic has been the number of people who claim to have had symptoms and who had negative tests. And in contrast to that, the WHO and many other jurisdictions have said that there is a very high percentage of people who are asymptomatic who are spreading the virus. So the truth is, we have absolutely no clue how many people in the community actually were infected, because based on your immune system, or you may have had a small cold and it was COVID, or you may have had a catastrophic illness and it was COVID. So the Living Lab is project is a way for us to understand within our own research institute how whether there was a spread of the virus that could have been in symptomatic or in asymptomatic patients. And over the next year, we'll be collecting blood samples from people, seeing if they have antibodies to COVID, and being able to understand in a healthy, highly motivated and very scientific population of anywhere from 1 to 3,000 subjects, how many people actually have antibodies to the virus and they may not even know they were sick.
So Bruce, we have a question from Andrew who is listening to us today. How can the rest of us get that antibody test? I think everyone thinks that they've had COVID-19, or maybe we're all hoping we did already.
Yeah, I think both Matt and I should address this because right now there is testing going on in our lab, in the hospital lab, OptiLab for the MUHC community, and at CHUM, and I believe in Quebec City, to determine the best tests to use for determining antibody levels in the population. And then the public health department will help decide who is actually getting antibody testing. I understand that within a couple of weeks, if not sooner, we'll actually have access. From my perspective, right now, the best way to get antibody testing, because it'll be sure, is to do it through a clinical trial, to do it through one of the projects like the Living Lab or something through the task force. But I know that they will be available clinically as well, especially for people who've been sick and perhaps for healthcare workers. And then in other contexts, the public health department will help guide us.
So Matthew, we're reading a lot about herd immunity and building those antibodies, and it kind of sounds scary when we say herd immunity. Is this something that we want, and how do we get there?
Yeah, it's definitely not scary. It's quite the opposite, actually. So herd immunity is a concept whereby it offers an indirect form of protection to the community or to the herd, so to speak. And the way it goes about it is that if there's a significant proportion of the community that is immune to the virus, it protects those that are not immune because the virus can't properly circulate through the community. There are two ways that we can go about this. The first of which is through natural infection, if a significant amount of the population is infected with the virus. But the preferred way would be through a vaccine. And the reason for that is we want to try to minimize and protect our vulnerable patient populations, but still find ways to protect them efficiently. And we hope that we'll have a vaccine to do that in the near future.
So Bruce, we're going to turn our attention now to vaccines. Everybody is eager to see one rolled out. And can you tell us a little bit about how a vaccine actually works on those antibodies?
Sure. So the best vaccine story in history is the original vaccination, where Edward Jenner took a little bit of cowpox from a milkmaid and injected it under the skin of a child. And there was a smallpox outbreak in the town, and anybody who received cowpox, which was a similar type of virus, did not get smallpox. So that was even before we knew what antibodies were. He just knew that milkmaids never got smallpox. So what is a vaccine? A vaccine is either the virus or the bacteria or a piece of the bacteria, like a tetanus toxoid or diphtheria toxoid, that is injected into people so that their immune system can learn in a safe way how to protect themselves against that particular virus or bacteria or toxin. When you give, we sometimes give killed viruses, we sometimes give parts of viruses, or as I said, we give parts of a bacteria, a toxin from a bacteria, something that will not cause an infection, or at worst cause a very, very mild infection, like you sometimes get with flu vaccines, but the overall protection from being exposed to that gives you protection against the real infection, which can be life-saving.
Matthew, I'm going to turn this to you. Obviously, you're working on vaccine development. There are many viruses out there, including HIV, that kill tens of millions of people, and yet we still haven't managed to develop a vaccine. Why are you so confident that we will for COVID-19?
I'm very confident about it, in no small part because I have yet to see a global mobilization of the scientific community as we've seen for COVID. I know that researchers all around the world are working at a furious but safe pace to try to develop a vaccine. For example, there are several companies in Canada that are working day in and day out to bring about a safe solution. And unlike HIV and some of these others, we actually know a fair bit about the virus in one that doesn't mutate at the same rate as HIV. And so with the resources that we have at our disposal today, I'm very confident that we're going to see a vaccine, a safe and effective vaccine for COVID-19 in the near future.
Now, Matthew, there are a lot of new technologies available to us in science. How has vaccine development changed over the years?
Well, I think it's changed radically. Well, as Bruce mentioned, we're no longer taking other viruses directly available in nature and injecting them into people outside of clinical trials. The field has certainly moved by leaps and bounds. One really neat example of a Canadian company doing some really pioneering research is Medicago, which is launched in working very closely with Brian Ward at MI4. And what they found is a way to manufacture vaccine through plants, where they inject the key parts of the virus in a plant-like system in order to manufacture tons and tons of doses. And a large part of their plant is actually a greenhouse. And the advantage there is their ability to mass produce vaccines to respond to the global needs.
So Bruce, we have a question from the audience about the link between tuberculosis vaccine and our and COVID-19.
So there's been a lot of interest in the link between other vaccines and protection against COVID-19. Tuberculosis vaccine is particularly interesting because what TB vaccine does is it supercharges our innate immunity, not necessarily our antibody system, but the system that recognizes things when the body first gets invaded. So BCG, which is the official name for which is the type of tuberculosis that we use for the vaccine, a killed strain or an attenuated strain of tuberculosis that's not as infectious. And it causes your immune system to recognize things. It becomes more adept at recognizing invaders as it comes in. And so TB vaccine could be a way to charge the immunity. But another approach has been looking at other viruses that look like coronaviruses. So there was a very interesting study done in the UK where they looked at the patterns of infection. And as we know, unfortunately, seniors, and especially people over 70, have been the ones who have been not only infected the most, but had the most complications. That may just because of age, but also what they hypothesized was that people who had received the MMR vaccine, measles, mumps, and rubella, may have some protection. Why? Because measles has about a 30% similar image or homology to coronaviruses. And German measles or rubella has almost a 30% resemblance. So if you have antibodies that resemble even part of the coronavirus vaccine, you may very well block its ability to infect you. If you look at places that had severe infection, in the UK, where MMR has been used since the 60s or early 70s, people who were only over 75 were getting infected. Whereas in Italy, where the MMR vaccine only came into play in the 80s, in the late 80s, people who were younger ended up hospitalized, and people in their late 50s and 60s ended up hospitalized much more so than the same cohorts in Spain or in France or in the UK. This suggests, and we have to study this, that perhaps other viruses that you've been vaccinated against can provide protection other than the protection you get from TB.
So here in Quebec, what you're saying, Bruce, if I understand correctly, is that people in their 70s and 80s likely did not receive the measles vaccine. Are you suggesting perhaps that they go out and get that today?
It may be something we recommend. We've got to study it a little bit more. This was an epidemiologic study. Epidemiologic studies give you hypotheses, and now we have to go out and see, does that really work? If you take serum from somebody with high levels of measles and culture it with COVID-19 or a similar virus, does it neutralize it?
So Matthew, we have another question from the audience. What happens if the US actually developed the first vaccine?
I'd be thrilled. I'd be thrilled if anyone came up with the first vaccine. I read a lot of things in the press that these COVID vaccines may be a bit of an arms race, but the simple truth is that's nonsense. In order to meet the global demand, we need to be able to vaccinate over 4 billion people. This can't be the responsibility of a single company. And the truth is that we're probably going to need to close to 10 or even maybe a dozen of companies being able to manufacture a safe and effective vaccine in order to bring about an end to this pandemic. And so we welcome news that anyone is able to have a safe and effective vaccine. We hope to be able to build upon this encouraging research in order to deliver the vaccines to people in our communities.
So Bruce, production of vaccines is really challenging. We are going to want to distribute evenly across all countries, from what we've heard from Matthew. Who will be targeted first? I mean, can we expect that the vulnerable community in Quebec would receive access first to the vaccine?
I think that if you look at the epidemiology of the infection, there's no question, like we do with flu vaccine, that we would want to target vulnerable populations. So flu vaccine is given free to people 65 and over, it's given free to little children, and it's given free to those with comorbid conditions. In the case of flu, it's asthma. For COVID-19, asthma has not been a problem, but other complications or other comorbidities like diabetes and heart disease have certainly been problematic comorbidities and have led to worse COVID-19 related disease. So I suspect that if in our system there is a rationing of what the government will pay for, then we will be then we will probably target the most vulnerable. However, considering the global effect on the economy, I think any government who is going to give out free money to the population to not work would much rather invest it in the vaccine and allow the population to get protected, and then they won't have to worry about closing down the economy.
So Bruce, we have an additional question about measles. It's drawing a lot of attention, of course. We have Helen who says that she did not have the vaccine, but she did have measles. And how do you feel about how protected she might be?
So theoretically, if she still has high levels of antibodies against measles, that would fit the hypothesis. Once again, this is a hypothesis. I'm not saying anybody who had measles or had measles vaccine is 100% protected. But I think that those types of questions are ones we have to ask as we go forward to understand why some people got severe disease, why some people got mild disease, why some people survived, why some people didn't survive. And these are, and then from that, we will learn things that will influence public policy.
So Matthew, we have a question again from the audience about what kind of vaccine trials are going on in Canada, and specifically about the MUHC, and how can we as patients get involved in that development?
Right, so as for most, and for all of these vaccine trials, we start with the phase 1, which is to say that we do a small cohort of individuals, generally healthy, to test if the vaccine is first and foremost safe. After that, we build to phase 2 and phase 3, which are larger groups of individuals, to then not only look at safety, but also efficacy in preventing infection from the virus. Now, in the case of the MHC, we are involved in at least 2 clinical trials at the Vaccine Center. We are very well positioned to be able to lead these clinical trials, not only at our local institution, but across the country. And for a lot of individuals who are willing to participate in this as volunteers, there's absolutely room to do so. I know that the MHC Vaccine Center volunteered, and it's actually not a problem to participate in these trials.
Now, Bruce, obviously you and Matthew have been promoting the benefits of vaccinations, but I'm reading a lot on the internet against vaccinations, and there's a whole movement, a global movement against it, and we saw the impact on measles around the world. I've actually, my favorite internet message now was that the virus was created by Bill Gates so he could, with his vaccine, insert us with tracking devices. How do you feel, one, about what we're reading on the internet, and two, how safe really are vaccines? Are there vaccines that we should be concerned about?
I think that people should read less on the internet. I think that I think that you have to be very careful about the sources. The internet is a wonderful tool, and yet anyone with a keyboard and the ability to type can become an immediate expert by becoming a blogger and putting cool pictures on his website. So, you have to really know the source of where things are coming from. When a COVID-19 vaccine comes forward, like almost all other vaccines that have ever been released on the market, it will have gone through really rigorous clinical trials. There's so much motivation for people to get the vaccine float that I know that there are at least 40,000 people who signed a petition to be human volunteers and skip animal studies. I'm not so sure I know how I feel about that, but I think that what Matt said about clinical trials is true. The safety and the efficacy will be tried. And if we don't get it right the first time, we're going to move on and get it right the second time. And I think that's the beauty of vaccines, and the reason the anti-vaxxers can take hold now is we've eliminated most of the vaccine preventable diseases. Nobody, when I was in med school, one of my friends did his med school in the Caribbean, where they weren't vaccinating to a great extent. And he saw people die of tetanus, and he saw people die of diphtheria. And I said, I've never seen anyone die of tetanus, and I never will. And I'll never see anyone die of diphtheria in Quebec or in Canada. You do not see severe measles except in people who don't get vaccinated. Chickenpox is a whole different disease now that we've had vaccination. Vaccination is extremely successful. It works. It's changed the practice of medicine. It's improved mortality greatly, and I don't think people should be afraid of a properly constructed, well tried out vaccine.
So Matthew, Andrew would like to know at what point, how long should you wait after you've had COVID to take the antibody test?
That's a great question. We know that antibodies to COVID can appear as soon as 1 day after the onset of symptoms. And by 3 weeks, almost everyone who's been exposed to the virus will have a positive antibody response. We are currently evaluating different study protocols to test people at large. We'll keep in mind the time of testing from the onset of symptoms. But to answer the question directly, 3 weeks after any symptoms, the person will almost certainly have a positive antibody response. Now, I should caution readers that there's a fair bit of data out there suggesting that if in some individuals who have perhaps immune defects or who had a very mild infection, they may not be able to mount a proper antibody response. And the second thing I would caution is that having evidence of a positive antibody does not necessarily equate to protection. There still is a lot more work that needs to be done on that front.
What do you mean by people with weak immune systems? Can you be more precise? Are we talking about cancer patients?
Right. So there's a group of individuals, and Bruce can certainly talk a lot about them, that are born without the ability to produce antibodies, for example. And in those individuals, no matter how many times they're infected with the virus, they simply can't produce the antibody. And for that reason, they will not be able to have a positive antibody test. Now, in most individuals with cancer who are not receiving treatments to specifically attack the B cells, the immune cells that are responsible for producing antibodies, they should nonetheless be able to mount a positive antibody response.
And can you be reinfected, Matthew, with if you've had the antibodies? Can you be reinfected with COVID?
That is the million-dollar question. We do know that after a first infection, individuals have, for the most part, a very robust immune response. But the duration of this immunity is not known. And so currently there have not been any convincing cases in the literature of reinfection soon after viral exposure. But if this drags on long enough, it may be possible. And we're drawing this information from other coronaviruses that are commonly present in our communities that don't cause COVID, but that do cause other respiratory diseases. And in these individuals, we know that reinfection is possible as immunity wanes. And these data have really strong implications for the vaccine strategies that we use in terms of potentially offering a booster shot and things like that.
So Bruce, we have a question from Sylvie about treatments. Is there a treatment that could replace the vaccine, for example?
So I think that's a really good question because we don't know the timeline for vaccines, and we are therefore not just working on how to prevent the next pandemic, but if it happens again, how can we make people's lives much more, how can we make sure people do not die in the same rate that they did this time? So we are looking at a few angles, and as you know, we talked about the clinical trials, and Matt can talk about some of the work that he's doing. One of the most interesting ways of preventing complications of COVID is to give people the antibodies made by others who've been infected. So there's something called convalescent plasma. someone who's been infected will have blood taken. I have a close friend in the New York area, New Jersey area, who she and her husband both were infected. And they both went for blood tests and both have antibodies. And in fact, the nurse at the New York Blood Services said to our friend, "You have the highest level of antibodies I've ever seen. Can you be a donor for hyperimmune plasma?" And she certainly was. So giving someone antibodies can definitely help attenuate the disease. It's been that way in many other diseases. And there's a clinical trial going on in Canada. MUHC is a partner in this clinical trial to test hyperimmune plasma. Obviously, there are other things that have been tried. Matt can talk about Plaquenil and can talk about antivirals and other things that he's been involved in. And as you've seen on the news, every second day a new trial comes out to try to understand how we can actually treat this disease.
So in fact, Matthew, Jessica would like to know if there are drug trials, and we'll have an entire webinar dedicated to various medications on July 8th. But can you give us a glimpse today on what you're seeing?
Right, so we at the MUHC are really proud to be participating in CATCO, which is the Canadian Treatment for COVID-19. CATCO is the Canadian branch of Solidarity, which is the WHO very appropriately named trial against COVID-19, where we are testing different treatment regimens, both antiviral and immune modulatory, to help improving outcomes for hospitalized patients with COVID. So far, globally, we've recruited over, I believe, 4,000 patients in the trial. We have very large numbers. We're very confident in our ability to answer these questions robustly and to move on to build on some of the really encouraging data that are coming out and to find the best possible treatment for these patients.
So Matthew, I'm going to stay with you and we're going to come back to vaccines for a few minutes because we do have continued questions from the audience. Now, it used to take years to develop a vaccine, and we've now reduced it to potentially 18 months to 2 years. Are we cutting corners, or are we transforming the way we do develop vaccines for the future?
Yeah, that's a great question. The truth is we are working furiously to try to bring a vaccine to vulnerable communities, to Canadians, to people worldwide, but we're doing it in a safe and responsible way. We already have preliminary results from several vaccine candidates in animal models that are showing very, very promising data, but we're not going to cut any corners. After testing these in the lab and in animals, we're going to do very safe, very rigorous clinical trials, such that when these vaccines become available, I'll be the first to recommend them to my parents, to my family, and to everyone else. I'm going to stand by these results.
Bruce, we've read a lot about asymptomatic COVID patients, and can you tell us about the spread? So are they contagious? If I am an asymptomatic and I have COVID, can I give it to my family, for example?
So there's no reason why you can't give it to your family. I know that the WHO, one person, sorry, it wasn't the WHO, originally they said that, and then recently one of their epidemiologists said that the WHO does not believe asymptomatic carriers can cause spread, and then she retracted that. You know, we obviously can't, it's hard to prove one way or another if someone was completely asymptomatic or not, you know, because generally you need to do something that releases aerosol. COVID-19 and other coronaviruses are aerosol or droplet spread. In other words, generally a cough or a sneeze, and not just somebody breathing on you or somebody running past you or somebody, you know, just passing you in the aisle in a grocery store. Those types of contacts, those minimal contacts with no aerosol would be very unlikely to transfer the virus. But if someone coughed and sneezed and they had virus in their nose and somebody else picked it up and rubbed their nose, yes, they certainly could catch the virus, even if the person does not have really overt, horrible symptoms.
Bruce, I'm going to stay with you for a few minutes. We're getting a lot of questions from the audience about risk factors for COVID-19. Can you take us through those risk factors?
Sure. So what we've seen is that the disease is very interesting in that in most pneumonias, you have people who have very, very low oxygen, but they also have difficulty breathing when they have low oxygen. And in many of the cases of the most severe COVID-19 patients, they have a low oxygen that's out of sync with how they look. And that's probably because there seems to be a lot of inflammation or congestion in the blood vessels, or microvascular disease, we call it, that's feeding the lungs, and not necessarily in the air spaces. The first thing is anybody with bad lung disease, in other words, a non-intact lung, like people with COPD, chronic smokers, have worse disease. Asthmatics, on the other hand, seem to be protected. Why they seem to be protected is that the medications that they take may actually decrease the receptor for the virus in their lungs. And there's actually going to be a clinical trial starting at the MUHC, which is actually going to look at that. People with other vascular problems, however, like heart disease, like strokes, like diabetes, which causes a lot of vascular problems, they seem to be at highest risk. So the stratification is the elderly, potentially because of protection, potentially because of a weak immune system, or other vascular complications, because unfortunately our blood vessels erode as we get older. And people with the comorbidities that we talked about, and also people with weakened immune system. And there's a whole project going on at the MUHC, and thanks to the MUHC Foundation, looking at biologicals, people on biological therapy, and seeing if they've had a higher risk for COVID-19 disease and complications.
So do my genetics and my blood type have an impact?
Absolutely. There was just a study that came out last week about blood type. Believe it or not, the 23andMe genetic analysis people actually said that it looks very much like certain blood types may be protective and certain blood types may be giving you more predisposition to COVID-19 disease. And there's the MUHC, as well as 11 other hospitals in Quebec, are actually taking blood from all COVID positive hospitalized patients and going to be doing a massive genetic study to understand risk factors for COVID-19. It's being led by a McGill professor who's a member of the RI named Vincent Mousser, and it's got major help from the foundations and from the whole RI community.
Matthew, we've heard that there is a pandemic about every decade now. What is your opinion on that?
That's true. And so far as we can tell, for the past 20 somewhat years, since we've been able to very clearly characterize these viruses, we've had a coronavirus pandemic. If you go back about 8 to 10 years, we had MERS. And prior to that, we had SARS-1. And there's no reason to believe that there isn't going to be another coronavirus pandemic in the future. And the reason for that is because coronaviruses live in bats. And then when these bats are able to frequent an intermediate animal, that allows the virus to adapt and mutate in a way that it can then infect humans. And so I hope that however difficult this pandemic has been, we're able to take away a fair bit of life lessons to inform us how to best respond when the next one hits.
Bruce, what is your recommendation for social distancing? We've heard Matthew talk to us about herd immunity. Should we all be getting together this summer and sharing COVID-19 so we can contribute to this herd immunity?
Well, since this coronavirus seems to spread much more readily than other coronaviruses, it's probably somewhere between 2 and 3 times more infectious than the flu, which has a high enough infectious rate. I think we're probably still best off until there's really none in the community with social distancing. There's 2 things that seem to make a huge difference. One is washing your hands like crazy. Every touch, every whatever. I think hand hygiene is really key because you'll be less likely to inoculate yourself with the virus. And the other is be intelligent about who you're socializing with. When the WHO and the Canadian government said that we shouldn't be wearing masks because masks do not prevent the spread of COVID-19, that may have been true, except that if you wear a mask, you're less likely to infect somebody else. You're less likely to cough on somebody or sneeze on somebody and everything, all the aerosol secretions to go forward. So in countries where mask wearing is common, like in Asia, They are able to control the spread in the community because people who may or may not know that they're infected can't spread it. So social distancing, washing your hands like crazy, wearing a mask when you're in potential contact with a lot of other people, like in a grocery store, all those things help. Nothing is perfect. Nothing will prevent everything, but every little bit contributes.
Matthew, there's been a huge toll of this pandemic. Thousands of lives have been lost in this province alone. There have been families divided by closed borders. People have lost their jobs. Can you leave us with any sort of hope for the short-term future as we look at this pandemic?
Yeah, I think that, but honestly, there's hope all around you. You take a look at some of the things that we're doing in the hospital and the communities, and you look around and you realize, wow, this pandemic has brought a lot of us closer together. And if you want some more concrete hope, you need not look much further than yesterday's news out of the United Kingdom. Some of the researchers did some fantastic job, and they found the very first treatment, dexamethasone, which is a commonly available steroid, that has been found to increase the odds of survival for those that are critically ill. And so while I recognize the toll that this pandemic has taken on us, financially, economically, psychologically, socially, it's important that we continue on a little bit longer. We've made leaps and bounds in terms of developments and discoveries of this virus. And what we kindly ask is that the public bear with us just a little bit longer. I'm confident that we're going to be able to come up with a solution together. And we appreciate everyone's patience, their trust in the meantime.
Bruce, Matthew, thank you so much for joining the time to answer the questions from our community. And I would like to thank you as well for asking your questions and for taking some time off today to join us. Tomorrow you will receive a copy of the video of this webinar. And if you've enjoyed our conversation today, we ask you to please share it with your friends and share it on Facebook, Instagram, and LinkedIn. And we hope as well that you will join us again on July 8th at 1 p.m. for our live conversation with Drs. Marina Klein and Makeda Semret on new medications currently tested for COVID-19. They'll help us understand how new drugs are developed, how they're tested, and of course, how they become standard of care. So thank you for joining us, and please stay safe.